right, welcome back. I hope everyone feels a little refreshed and ready to keep going. Thank you for your patience, and we'll get started. Now we're going to move into a longer session of questions and answers. First, we're gonna tackle any direct questions for Chris, Alan, or Liz based on their presentations about the future of health care, the future of health IT and where the market is going. Then we will switch into a little bit more of a conversation between you all, with each other, and with the panelists, and we'll spend the rest of the time together doing that. So I will bring the microphone here. We have another one in the back. Any questions for Liz or Alan or Chris based on their excellent presentations? Well, then let me ask my first one, and then that can spur us on. We may just move, though, into the longer conversation, because they do tend to bleed into each other. My question for the three of you is, what is the future of health IT? Where is this going to be in 5 years?
It's going a lot faster than I think any of us anticipated in terms of some of these things. I mean, you can hear just even in terms of Chris bringing his, the projects he showed you. That's right. I mean, just think about how fast this is going. So a lot of these things are already on the way. I think the Internet of Things piece is going to sort of take on a life of its own too. It's really getting a lot of buzz in sort of the technology side of the world. Now, there are real issues that still need to be addressed in terms of security. Do you want somebody hacking into your thermostat? Right? I mean, that doesn't, so they make my house colder. I live in Cleveland, so this winter that would have mattered, I'm just saying. But, I mean, I think there are things about, if you think about being able to hack into things that actually have health influences, but these aren't insurmountable. So I think there's going to be a lot of sort of the same kinds of things we've dealt with other things as we worry about privacy and security. There are ways to address these things. We just have to figure those out, too.
Well, I think, the Internet of Health Things, I guess, is really going to be a wonderful place in about 4 or 5 years, I think, and certainly not without challenges. As Liz mentioned, I think from an IT perspective, security is a key issue that needs to be addressed. Secondly, interworking or interoperability. You've seen this in the telecom industry, in the Internet industry over the last couple of years. Many of these issues have been solved. But interworking with respect to data and information that's critical for maintaining EMR, EHR, I think workflow and then also, as Chris mentioned, giving the organizations what they want is very important. So it's really working on what we will call the user interface, the UX, UI. Those are all very important pieces of work to be done, because otherwise you're going to get so many different systems. Every time you turn around, you have to learn something new, and that's going to take time. But also a drive for simplicity in the way we do things from an IT perspective. And then also, within the home, if we're really focused on the home, how to drive performance as well. And secure those various things. But I think the Internet of Health Things is really going to have a lot of benefit here. It's just a matter of getting really crisp at what we need and building that in the interim.
The cost right now. Cost is a concern. Like you showed a consumer with a tablet. I mean, I would see that the future, how can you make it cheaper? How can consumers use their own tablets? How can you have this to a lower cost of a person behind it monitoring or patients self-directing? So the whole idea of the role of a home care type agency versus a different kind of provider has me sometimes puzzled in how to do it cheaper. I don't know what your thoughts are on that.
Well, I think on that specifically, I think as we continue to move toward interoperability and some of those things as organizations are looking at, being agnostic from a standpoint of, I mean, a lot of them have moved to be agnostic from a standpoint of cell carriers. A lot of the apps and those type of things are agnostic, whether it's a Android or an iPhone or any of those type of things. So that process has started. So to push the cost because it's not reimbursable everybody tries to push the cost to somebody else. And so if we can push it to the actual consumer using some of their devices, then obviously it helps reduce the overall spend for us in this room. So I think you'll continue to see that happening. From a standpoint of where the technology, I think, is going to make the biggest play for us in this room is there are opportunities for, again, the organizations, whether it be an ACO or even just a hospital, that there are large non-Medicare populated patients that the hospital doesn't know how to take care of once they discharge them outside of the walls of the hospital. They're still on the hook for. And again, if you haven't started to talk inside your organization on how to use these types of technology to take care of that patient population, it's probably something to start discussing, because every hospital I go into, and part of my role is to work with my Medtronic counterparts and I'm getting on a plane right after this to fly to Milwaukee to meet with a large hospital system. They're looking at ways to manage that non-homebound patient population that's getting sent home with COPD, CHF, the 5 chargeback areas. And they don't have, the reality is they don't have the resources, nor do they want to have the resources to do it. You know, they're great at, that cardiac surgeon's great at, cracking a chest and doing that. Last person I would want being in my home taking care of me on home visits. So they're looking for those resources, and us in this room and in our industry is where it needs to be. So think outside the box, take off the blinders, and look at how the technologies that's available for you can be used to increase the size of pool of patients that you might be able to take care of, which will put you in a better long-term position over the next 5 years.
And I think that's what I was trying to say earlier. Remember, we're trying to move stuff back into the disease trajectory, right? So we're trying to catch people before they're going to be people who progress anyway. But I think there's a lot of emphasis and a lot of opportunity for all of you right now to actually sort of refocus on the health promotion, disease prevention pieces that we used to do in home health care. Those of you who've been around a long time remember those days. It's sort of everything old is new again, and I think it's an opportunity for you to really take advantage of that. And technology enabled, right? So we're not necessarily replacing, because that's the other thing that comes up is when telehealth, remote patient monitoring stuff first came out, there were nurses who were concerned that they were going to be replaced. Right? It turned out it didn't really replace them. It enhanced what they could do. It didn't, there was all this stuff about, well, we can drive the number of visits down. We don't have to do as many visits. Well, what we actually found out is the person sitting behind them at the screen at the office, right, that's a pretty intensive thing, because they're using their clinical judgment. It was a different kind of care. So it's going to change what you're thinking about in terms of your traditional Medicare patient. Move it back to what that patient was like 5 or 10 years before, and see what you can do to prevent them from ending up where they end up. Because I think that's where there's opportunities. I agree totally.
Most likely your biggest competitor is not going to be the home care agency down the street. In the future, it's going to be an ambulance company or other organizations that are looking at doing those home visits and trying to do them at a lower cost, probably most likely a lower quality. So that's why I think, keep looking at the things that Liz just mentioned.
And the other thing I said when we were chatting this morning is that home care agencies, compared to all these other different models of care, patient-centered medical homes and all these things, you're the only people who could put feet in the house that day. You're staffed to do that if you have to. And these other providers can't do that. They're not staffed to do that. The patient-centered medical homes, the providers, they're doing great things, but they can't put feet in. And some days, you know how it is. You have to actually put your eyeballs on that patient. Right? So that's where I think you have an opportunity to sort of explain what you do and what you can do. And that's where I think there's lots of opportunities. I don't want you to miss those. Because I can tell you what's going to happen, exactly what Chris said. Somebody else is going to move into this space, and it'll be done.
Yeah. Do you want to?
I want to comment on that a little bit, because I think that.
All right. Yeah, we're gonna have. Sorry, I took one of them. We're gonna have to balance this a little bit. But Liz, why don't you go ahead, and then we'll pass this back.
Go ahead, and we'll get into comment.
Go ahead.
Okay, I'm gonna say something a little slightly different. I was just because I had a question for the group around what was said previously around other types of payment beyond Medicare. So I was just curious to know in the room how many folks are being reimbursed from Medicaid. Terrific, and private pay. So in particular, I'm interested in social for like private in-home like non-skilled services. And so, and the reason why I'm asking that, because I think that's another opportunity. Certainly, as I mentioned, I was touching on that in my presentation around social services and having that and leveraging your non-skilled workforce as a first point of you know, care to push that information back up to your care managers and other folks that are sort of managing that individual. So we certainly see that, collecting that social service information as a key opportunity, because I think that's sort of one of the information gaps that we see today.
What Liz said about boots on the ground, I think that's where we see this perhaps going. And I was talking with Rene at the break about the fact that, and not to diminish what you guys do with Cardiocom and Philips and Honeywell and those, but I think someday people will go to Best Buy or Walmart and buy devices that they will have that will enable them to hook up. But that's dependent a lot on broadband access. And so my question to all of you, and perhaps Rene, because of their Washington connections, would be best on this. You know, President Obama wants there to be a almost public utility aspect to the internet that would lower the cost and would provide the opportunity for more people to have access to broadband, not dissimilar to what, when we first started doing telemedicine, we were all hooked up to the plain old telephone line. Now about half of our patients have said, screw the plain old telephone line, I'm going to my cell phone. But that presents yet another problem on this. So my question really more appropriately to define this whole rambling is to how do we think that future of broadband access, and certainly it can't be in rural areas as much as it could be in urban areas, but is that going to be more of a public utility concept over time, or are we going to face the fact that this data access could be $50 to $100 a month for each person, and older folks on fixed income, that's a lot of dough.
So I'm going to answer that in a sort of circuitous route, which is, I mean, I think what you're identifying is a real challenge and a real opportunity for us to advocate and to explain why a more universal broadband is important. I think it's a little out of scope for this panel because we aren't able to solve that. I will say, having worked with VNAA on their comments over the years, we always include that when we talk about the challenges for rural communities in accessing health IT and bringing that to bear across the tables. I think it is something we acknowledge, something that we will work on, but is out of scope for those of us at this table to really solve. Although, clearly, if it is solved, it makes our lives a lot easier.
One thing is that Best Buy did last year, they did a big push on that. It didn't go very well, but I do think that will come about. Bottom line is, no program is going to be, if any program, whether you buy it at Best Buy or from a healthcare manufacturer, if they don't have y'all's resources to do something in the home, the only thing it's going to do is increase ED visits. So there's still a place, if positioned properly, for what we do in-home health services.
Any other questions directly about the technology? Yeah. A microphone right behind you.
This is a question for all of you, for all the panel. I'm just wondering whether the technology effort moving forward is more consumer or provider-led, if you will. Who do you see as pulling the horse carriage? Is the industry kind of waiting to see, you know, what patients are interested in with things like the uptake of things like fuel bans and things like that? Or is the industry kind of trying to push it in one direction? As the leaders of the industry, how do you see it? Do you see it as kind of looking at what consumers want, or kind of telling them what they need? And or is that kind of it's moving together, and you're going to kind of, it's going to be an iterative process? How do you see that?
Well, right now it's still, if you look at numbers, and that's still provider driven. Even on Fitbits and numbers, if you look at use of a Fitbit from day of purchase, 180 days out, what happens to that? So because of that, and again, this piece that Best Buy did to push home, basically home remote patient monitoring, you can go into a Best Buy now and good luck trying to find it. So it's not there yet on the consumer side. When I was at Home Ed and Honeywell that was why Honeywell, really bought us back then. So right now it's still being driven by the provider. I do think as we take more and more of our own responsibility from the consumer standpoint, it will get there.
Yeah, I would agree with Chris as well. I think, you know, the consumers will ultimately have a say in this. Again, they're the ultimate user of a lot of this technology. I think even at CES this past year, there were, what, several hundred wearable lookalikes, right? And, you know, I think the market will ultimately yield what will ultimately win in the market. So,
So there's this group of people, if you want to do an interesting Google search, look for the quantified self movement. So these are people who keep very detailed track of all different kinds of parameters about themselves, and they post it on the internet to share. First of all, I'm not going to share what I eat every day. I'm just telling you that right now. So I mean, you know, or you know, what time I go to bed and all those kinds of things. But there are people who do this and they post this kind of stuff, and so I think that's the unusual part. Yeah, well, yeah, it's even more than Facebook, Rich. I'm just saying. So, but the quantified self folks are unusual, but they're really sort of pushing the edge on things, and so they're sharing things. But what they're also doing is they're coming up with insights, and I think that's the thing. So it's not just that they're collecting a lot of information; they're coming up with insights. And so if you look at that, some of them come up with things about, gee, what I've noticed is my sleep patterns start to deteriorate, and then I start feeling more depressed. They're able to actually sort of find some actionable things. So maybe it's my sleep that's interfering, that's leading to my more depressive symptoms versus my depression, right? So trying to sort out how it works for them. And so the quantified self movement, I think, is one of the ones that will help us figure this out. You know, I don't think any of us, I mean, a lot of people are never going to do that kind of thing. But I think trying to figure out how they're making sense of those patterns is what we need to learn.
An excellent question. Thank you. Technology question? Thank you.
So I guess this question's for Alan and maybe Liz. I was thinking about before, you were talking about this predictive analytics and trying to use it to determine what's happening to a patient. What if we flip this around? Is there any research that's being done that looks at using predictive analytics to determine who should get the technology? Because I think this is one of the challenges. We're trying to broadly use this technology with populations where some of them it's going to be effective and some of it's not. So can you comment about that?
yeah, I think that's a good question, and I know in Philips the research team is just starting to look into this, right? So you have the analytics, but you also have you know, prediction as well, right? And I think that's also part of what we're trying to do with our CareSage model as well. Specifically, not so much if you have the data, say, let's say fall detection, but you know, other kind of signs and other data that could go into some of those analytics. So it is possible. I don't really have any details as of yet, but I think it's a good concept to consider.
There are a couple benchmarking softwares and EMRs that after you finish your start of care, they look at all the new answers and put a predictive model on if somebody is a high probability of a readmit. So.
Yeah, I know about that, but I'm thinking a little bit more broadly because you know we've got people who have cognitive challenges, you have people where I can talk. So, you know, we have patients with cognitive challenges. We have those who just maybe won't be able to physically use the devices. There's lots of reasons why we may not want to deploy this. And I'm not saying we shouldn't, but I think the reality is it's too costly to put in every patient's home. So we should use it on those where we think we're going to have the most benefit.
Anything else to add? I'm going to shift us a little bit now. Away from the direct questions on technology, although clearly that will be infused, but into more of a conversation where we can lift up the best practices that you all are seeing, have responses up here, and highlight other issues that our panelists want to touch on. I think we are really interested in hearing what your agencies are doing, what the barriers are, any unique enablers you have found that make it easier to implement telehealth in your practice. And we'll share those as well. To start that, I'd like to invite Candace Curtin, who is from North Carolina in the back, to tell a little bit about her experience in North Carolina at NHRMC Health Center, where they've done a really good job both integrating the technology and also proving outcomes. Candace?
So to speak to the agencies who are not owned by a hospital, because we are affiliated with a hospital. We have 3 different hospital systems. One's critical access hospital, one's an orthopedic hospital, and then one's a level 2 trauma teaching center with 855 beds. So it's a large organization. They've received several awards in both ortho, trauma, rehab, cardiac, you name it. Our agency actually does have telehealth in place. We have protocols set up with the local offices. We actually own 100 different doctors' offices that are within an 8-county radius, so a 60-mile radius of us. And then what we found was we put all these great protocols into place and we put telehealth into place, but still we were having readmissions mostly outside of our agency with other home health agency patients. So to speak to how you guys can approach your hospital, what we decided to do was go train those agencies, get them on our policies, get them on our protocols, let them do what we're doing, teach them how to do it so that we can all, you know, we'd rather reduce hospital readmissions than worry about a lost home health referral. So go to your hospitals and partner with them and say, how can we help? Because especially if they're going into an ACO environment, which is where everybody's leading, at that point in time, it really doesn't matter where the home health referral is going to them. That's not where their money's going to be coming from. They need to make sure that these patients don't come back. So you can partner in that realm, and I think that's important to go and speak to them and say, how can we be of help? How can we get on the same page with you? Because you don't want our patients readmitted, and then you're on, you know, some equal playing field again. So to speak to that, for the cardiac program that we have a full CHF service program, so we actually can give IV Lasix in the home. We have a cardiac nurse who monitors telehealth. We actually have 2, and we have a telehealth installer. We got a grant from Verizon for $300,000. It's a 2-year grant that we're in right now. And I did find out for sure that it was a nationwide application. And they came down, met with us, looked at our procedures and policies, made sure everything matched up legal-wise. In the first 6 months, we only looked at CHF patients right now, although we have 4 diagnoses that we use for telehealth currently, if you don't count our wound care program at all. But actual telehealth monitoring, you know, which I'm looking at a little separate than digital photography with wounds. But our CHF program, we went from 12.8% readmission rate in the first 6 months after this Verizon grant began to 7.6%. So that's a big reduction in 6 months, which can save a hospital a lot of money. So if you can bring that kind of data and those kind of results in 6 months to a hospital, they're going to work with you no matter whether you're their agency or not. And the other thing you have to think about is when we went into this ACO, we went into it with Blue Cross Blue Shield. It was one of the first in North Carolina. And Blue Cross was very adamant about, we don't care if you have a hospital home care agency. We're telling you in advance we want the best agency with the best outcomes. It just so happened that that did happen to be us, but we were lucky in that event. So hospital-based agencies are not always the preferred agency when you start talking ACOs. It's the ones with the best outcomes. So it's important that you implement these programs, that you implement them effectively, and that you work in partnership with all the agencies and hospitals and facilities around you. That's all I wanted to say. Oh, and come see my poster tomorrow. It's on wound care, so it'll just help you decrease your patients that you have on wound care and your costs there. But I'm with NHRMC, New Hanover Regional Medical Center, NHRMC, in Wilmington, North Carolina.
We had a hand over here.
Thank you. So I heard a lot today around, demonstrating our value or proving our ability to demonstrate outcomes to various referral sources. From what I'm seeing, many of the referral sources are actually collecting that data themselves. I'm part of a large system, and our home care agency is part of the system as well. And I know that all 6 of our acute hospitals have started going to a discharge planning platform that actually collects the data for them in terms of the percentage of patients being rehospitalized from skilled nursing facilities and home care agencies. So they're able to break down that data pretty well, and I know we talk about it a lot and our inability to provide the data. I'm wondering whether or not that really needs to be something that we as an industry are focusing on, because my sense is that the referral sources are already focusing on that and probably can collect the data on us better than we can on ourselves. So that's a question really, and I think, just a comment from being part of a home care based hospital system. I don't know that I agree that all systems feel that there's a value in using anybody that can provide a better outcome. I do think more and more systems are trying to prevent outward migration. They're trying to reduce the costs per episode, visits per episode, et cetera. So I think it's a lot more than just outcomes that systems are looking at. There's a lot of money involved here, so I would just be cautious around that. And I think that as part of a system, very often they look to us to provide things that other home care agencies are not willing to do, whether it's a visit just to assess somebody that's not billable, whether it's putting in telemonitoring that's not billable. So very often they do look to their own home care agency to provide, I think, services that others are reluctant to provide because of billing.
So let me open the question to the panelists. Does anyone want to tackle tracking outcome data and the need to report?
So I'd be interested in how many of the rest of you have worked with systems where the discharge planners track that. Is that increasingly? Yeah, so it's starting, and I think I think this is where you're going to start seeing more and more of this. Of course, what this does is then this, depending on how you show up on Home Care Compare, right, which we all know has its own limitations, I think there's lots of information for hospital systems to keep track of, right? So it's the Home Care Compare data, it's the own data they have, because, Home Care Compares all the patients, and we know it has the time lag, but if they have actual data that shows that, one home care agency has lower rehospitalization rate for their own patients, certainly that's something they're going to tune into with good reason. And this is even before we start getting into bundled payment, right? So I think once we start getting into more bundled payment, it's going to get even more complicated. And again, I worry because home care tends to be at the tail end of the continuum of care. Are we going to be the ones where things fall apart? So it'll be it's an interesting time. It's the old Chinese curse, may you live in interesting times, right? That's where it is certainly interesting times.
I would say, and not only on the health systems, but Blue Cross has been mentioned a couple times. They have claims data analysis that is well more in depth than anything that we could provide. So there's other ways to get the data on how it's going. But yeah, I was just with a hospital last week that their whole discharge planning group is doing exactly what you just talked about.
Just particularly on the data, excuse me, thank you, broke my own mic rule, particularly to the question about tracking outcomes and data. Yeah, here, and then we can go back to Candace.
Just a data question. I haven't heard anybody tracking and measuring patient engagement, patient activation. Because to me, I think that telehealth does that, and then your avoidance of hospital readmissions maybe is a byproduct of that. I don't know if anybody's measured any of those kind of things.
Any response?
So it hasn't really been done well in home care patients yet. It's been used in especially self-management research. It's a very common piece that is one of the elements of self-management research. The patient activation, there's a patient activation measure, PAM is what it's called, and what it really identifies is how much the patient sort of buys into the care they need to do. The other piece I think that's increasingly coming out in sort of the research literature, and I think this is particularly appropriate for home care patients, is now there's an issue of treatment burden. So we think about patients who we say it's time to self-manage. We have this sort of whole thing about patient as partner, right? We're going to partner with our patients and all this kind of stuff, and it really essentially puts a lot of work on them, some of which they don't want to do, and they're, oh, by the way, not going to do, right? So that, patient engagement is one part of that, but treatment burden is the other part. So are there ways that we can sort of identify what treatment burden is? So, think about the patient, your typical home care patient. They have 6 or 7 diagnoses, all of which, even though we have to identify a primary, all of which impact how many medications they take, how much self-surveillance they have to do, all these things that we want them to do, and there's a treatment burden associated with that for people who are older, frailer, and are going to have less cognitive intact pieces because of the aging brain. So I think it's something we really have to pay attention to in terms of patient activation, but also treatment burden. So.
Okay, and I just wanted to comment back to what you were saying. Again, when you're dealing with a hospital-based system and that's your barrier, I think it's important to mention the ACO environment, and that's what you're headed to, because initially, yes, we were on the path of, we want all the referrals, we'd like all these other agencies out, that was our focus and that was our drive, and that still may be the drive for many systems that aren't prepared to go to ACO anytime soon. But if you will take their focus, it will take a meeting of you sitting down saying, but look at what you're really looking at are readmissions and your penalties that are coming with your readmissions. That's where their drive will come in. And it's also affecting you, offer things like we still monitor our telehealth patients even after we discharge them, if we discharge them, fast within that period of readmission for the hospital. And that's something that a hospital will perk their eyes up about, because even though you're not getting paid for them and you're not getting paid for that service, you also don't want them readmitted because it's a partial episode payment for you anyway. But it does get you referrals more so in the door, and it makes hospitals want to work with you more when they know you want to work with them. So that's just another approach that you could take there.
Other questions or experiences to share? Then I'm going to ask anything initially. I'm going to turn to Liz then. This Liz. To talk a little bit about, and I think it stems nicely from the point that was just raised about what's happening to the patient in the home and in the community, and how to bring other sources of data to bear, including community-based organizations and other sources of data and information that are impacting your patient and their quality of life that can be brought in and monitored.
Yeah. So, I think one of the things to note is really there's been certainly a push towards deinstitutionalizing folks and having them receive treatment and care in the most appropriate setting. And so I think home care really has a role to play here. And it's certainly managing the clinical episode, but also, again, those social services components. And so thinking about the transportation needs and the meals and any other kind of supportive services. And so really, I think a lot of times what we're seeing in the work that we're doing at ONC is there's just, there's such a fragmentation in terms of how all of this is managed, in terms of the kinds of systems that the social service providers have. And again, the lack of communication. And so many times, even for an individual, they may not be aware of, the whole host of services that they're receiving, who's coming at any one given time. And, so it's really important, I think, as well in our work to figure out what is our person's preferences and goals, and really supporting that person's life at home with understanding sort of, maybe it's that they really cherish their walk every day. So if, you can arrange some of these services to come at a different time to enable them to meet certain of their goals, those are really important aspects, I think, to the quality of life. And so it's certainly something that we're focusing on, again, this notion of capturing a person's preferences and goals, and then the conformance of how the services and care that they're receiving marry up to that.
Well, and so let me take a pulse as we kind of stop there. Are any of your agencies implementing practices that capture community services? Can you speak? Are you willing to speak to it? I know I've lost the second.
How's it going?
Yeah, how's it going? Is it working?
How are you doing coordinating?
Is there, where's the second mic? Well, here. I've lost.
It's part of a community effort. from Vero Beach, Florida, Indian River County, where you get your oranges from if you're from Florida. Go ahead.
Well, first of all, the county that we're in, we have about 80 home care competitors. And I know in some urban areas you've got hundreds, but for us we have 80. We're the only not-for-profit agency. So we do have a distinct advantage to be able to partner with other agencies that are based in the community that serve our seniors, one being Senior Resource Association, which offers adult daycare. They offer Meals on Wheels. They offer socialization for seniors. There is a program for homebound seniors that are alone that has volunteers that call them every day just to chat and check in with them. It's not a medical conversation that they have. It's a socialization for seniors that are alone in their home. And it's the same person that calls them every single day. I'm trying to...
No, go ahead.
The Alzheimer's Parkinson Association, we work really closely with them because obviously a lot of our seniors, you talked about comorbidities, and it may be someone who's had a cabbage, but they also suffer for Parkinson's. So we don't always partner with these other organizations for the patients, but for their caregivers. We've offered in both ends of our county panel discussions for caregiver support, and we've been talking a lot today about patients, but engaging the caregivers is key to patients coming out of the hospital. It's the discharge plan, and sometimes our hospital, they don't plan very well, they just discharge, and I know that everyone in the room is probably experiencing that. But the equation is threefold, and it really involves the caregiver for the success of keeping that patient at home. So if you can support the caregiver, and I'm not taking anything away from the patients that we care for, but it's the caregiver, because Liz Madigan said, the average age, first of all, let's say our patients are 85. They either have a caregiver who is 85 as well, with his or her own issues, or no caregiver. So a lot of the organizations that I'm talking about not only just support the patient, but they support the caregiver with activities for them as well, respite care, those types of things.
And can you speak to how you use technology to help make that easier? Or are there ways that Health IT lets you communicate with the caregiver in different ways?
Well, we've been using telehealth. We're actually in our second generation of telehealth, and we started, like a lot of you, with, they had to be connected to, a landline, that type of thing. We were one of the first home care agencies that started using the latest CardioCom. I think we were the third or fourth in the country to use that. So a lot of times, and I know someone mentioned before, the patient who is coming home on home care cognitively can't operate the unit. So again, it's that caregiver or whoever's coming into the home. It might be the adult child that's coming into the home. And a lot of times in patients that are more affluent, it's the housekeeper or the private aide that they have. So again, it's utilizing those family members with the technology that we have.
Let's turn our attention to let's keep our attention for a minute on the caregiver. Does anyone else have recognizing the unique privacy and personal concerns of the patient who may or may not want their information shared? Is anyone else using telehealth or remote health IT broadly to better coordinate with caregivers, to coordinate with caregivers across distances, or to bring that to bear? I guess I open that to the panel too. I don't know why I'm standing. Let me sit so I can pass the mic. Nothing? I think yes, a family portal, the ability to access data.
Maybe FaceTime on an iPad if they can.
Kind of thing. So they could have maybe a remote family member having access, something like that.
Yeah, it's hard with the one that we're doing.
We don't, but I do believe that this is a huge market for somebody living in Cincinnati with a son and daughter in Seattle And right now, I am a grandparent, so I use Skype a lot. And it's not as good as being there, but it's a lot better than anything else I can think of. And I do believe that in terms of funding this, if you want to think about a true willing partner, it's that son or daughter who lives far away from a parent who might be willing and able, perhaps more able and certainly willing to pay for that service, but doing it is a whole nother bag of tricks, and making that service available, understanding the limitations of it, understanding the privacy issues that are involved in that are very complex, but I do believe that at some point this is going to be a huge market, much more than it is now.
I see a couple of hands up. Liz, you want to respond, and then Bob, and then we'll come to front.
Yeah, only in fact, I mean, only in the nature of the fact that, you know, we used to do this, but we used to do it by phone, right? So, I mean, it's really, technology just enables a quicker connection, or if you can work out all the other issues that you talked about, which are very important. I mean, don't misunderstand me, the privacy and all those pieces are really important, but I mean, it really is sort of just the next generation of what we've always done in home care. So it's the advantage of being old like me is you have perspective, right? So that's what I tell my children, I have perspective.
I'll just add a comment. I think it's a beautiful idea. This is one of the things that we're actually working on as a caregiver portal that does just that. You know, and this is also part of the Health Suite digital platform. So not only do you have this repository of data that's specific to your customers, but it also allows for caregivers to get access to that data that's already been exactly baselined or optimized for what they want, you know, and it's not just going to be a computer-based website. It'll be mobile, tablet. You'll get alerts, you know. You'll be able to, you know, set up a very quick video conference call using the technology that you want. It doesn't have to be specific to whatever is built. It could just be a connection of FaceTime or Skype. So all that's coming, it's an amazing idea, and you know, if you pay a little bit for it, that's fine. But it'll certainly, I would love to have it. I think, you know, it's got so many benefits.
But it comes back to broadband access.
That's true, right?
Again,
Oh, go ahead.
I was just going to say we can't solve broadband. It comes back to it, but we're not the people who can solve that.
So this is it's a comment more than a question, I think. I mean, one of the things I've noticed is that there aren't really great portals for home care patients. But if you look to see what's been developed for like the hospital systems, there are actually some third-party products out there that do exactly what you're saying. They do the video, they engage the patient, they allow them to even chart. And I think that this is really a question, you know, an issue with ONC, in that the money wasn't there for meaningful use for the post-acute setting. And given it was there for hospitals, you tend to see that it's been developed. So I don't know if this will be resolved, because there has to be a business case, but the reality is there isn't enough money right now really to build out some of these systems.
Yeah, I mean, I think, well, for one thing, I just want to clarify that it was the High-Tech DAXO Congress that, not ONC. I think ONC is certainly trying to help support the space. But we're doing quite a few, partnering with CMS, actually. I mentioned the TEF grant. So part of what they're doing as their demonstration is actually doing a lot of focus groups around portals. Particularly with, again, Medicaid waiver recipients. So elders, persons with severe mental illness, and some other of the waiver populations. So I anticipate in the next few years we'll have some really interesting data about the evolution of some of these portals for specific populations.
Yeah, absolutely.
So because a lot of the technological advances happen on the coast, and I say that being from the Midwest, I can tell you, I'm not saying that, that's where it starts. So there's some really interesting data coming out of Kaiser Permanente in California about the use of secure messaging using the portal between patients and providers. And it's not it's not the group that we think about, which is sort of the middle class, more educated folks. What they're actually finding is it's actually, the uptake is faster among the lower income and the people with the lower health literacy. So this is moving pretty quickly, and they've seen great increases in just the past 3 years. So I think this is just, I think it's on the verge, but it's not, I don't think it's far away. And it's you know, I think what's going to happen, again, like we talked about earlier, is that it's not going to just be the technology or the providers providing this that'll make it happen. It's going to be consumers saying, wait, if I can do this with my physician and my physical therapist, why can't I do it with my home care nurse? It's going to be driven by, right, it's going to be driven by the consumer demand, I think, is where we're going to actually see some traction. So I'm hopeful. I'm hopeful.
Hi, I'm Andrea LeQuay with VNA Home Care of Central New York. And our organization is a little unique in that we've got several parts to it. We've got to manage long-term care as well as our CHA and licensed agency. And we're finding more on the consumer side, you know, as you said, flipping its way over. And what we're doing right now is exploring, it's called LifeShare Technologies, and it was a program that typically was used in like nursing homes, and it kind of reminds me of like your hotel channel on the TV. But it actually overlays the cable system for our elderly population, who most of the time they will watch TV. For us, we're using this, or our plan is to use it as their technology continues to develop, is as reminders. They get telephone calls that we don't generate, that are automatically programmed in about their transportation, their ride coming to get them in half an hour so that they're ready to go, that they have an appointment. There's family portals to that. Families can send text messages and emails and pictures, and it just shows up on their TV. So again, it's a way for them to be connected to their family that's far away, but also as a provider both of their CHA services and their insurance product in many instances, to be able to balance all that, to the point that if they've taken their medications, they may have to reply with their remote control that they took their medications. So it's all of the monitoring and being able to stay connected with them and their family so that communication can happen. But you know, one of the questions I asked when I first saw this was, okay, where's the security? And there's a pause. Because that's not the end that they work on. It's, you know, so it's something new for everyone to really come together with.
The question was what cable system?
I think it's any cable system, but we have Time Warner where we are. It's via the internet. As a provider, as the MLTC, it's something that we're looking to pay for specific populations of people that would benefit from this. So it's not every patient that's in our program, but certainly for those ones that we believe will benefit from that connection, you know, for their family, isolation, those kinds of things. You do have to have Wi-Fi. I mean, you do have to have the ability to have internet.
It all comes back to it. I can't solve it.
But again, for us as a plan, an insurance plan, and that's one of the things I love about what we do. You can kind of be that common sense insurance plan. We can do a lot for patients who this would benefit them. So for us, it's worth it.
Any questions about that? This is particularly innovative, I think. Those are the things we'd like to lift up here.
The managed long-term care? The insurance product. The insurance Our product. Specific, yes, but there's many models across the United States that are managed. Managed Medicaid is what it is.
Is there an add-on cost to their cable bill for this?
No. We would be paying for the actual use of...
Hang on. Wait. Let's make sure everyone can hear it. Want to ask the question again, then we'll re-answer it?
Is there an add-on cost to the cable fee for the patient?
No. It's just what we pay as the provider to have that service available to us. You know, when you think about it, we hire people to call these patients to remind them the doctor's coming or that they have the doctor's appointment, that they got to go to a ride.
Is it a fixed cost? I'm sorry. Is it a fixed cost to you, or is it an incremental cost?
It's fixed. I mean, it's per patient, but again, as our population grows, we can kind of shrink that cost.
Other questions on this? Anyone else have an innovative model or something similar to share? All right.
So the thing that we really haven't talked about, which actually is sort of striking sitting here thinking, is that we haven't really talked much about behavioral health, mental health. And so you know, Chris sort of brought it out in one of the groups that he identified for where we have a future to grow. But I think the other piece is that for remote patient monitoring, the remote patient monitoring research on patients with psychiatric disorders is actually really positive. Unlike the mixed stuff from the other one, it's actually very positive in this. So this is one where I think there is traction in terms of having the evidence you need to go to your Congress people about. But are people using remote patient monitoring for patients with mental health, or do you have specific mental health programs and conditions that you've been doing that with? I think she's got them.
Do you have the do you have the mic?
We don't have it, but I've gone to every month we have in Kansas City, we have through the Mid-America Regional Council a digital drive session which talks about innovation. And there are several programs in the metropolitan area in mental health that are using algorithms based on facial cues that tell people about based on certain questions, based on how these algorithms go, whether they're candidates for depression or whether they would be likely candidates for doing something even worse than that. It's in the very formative stages, but there are sites where people can go in Kansas and get go to a registered site and get counseling to a provider, but again, it's not in the home, it's in another setting. And that has been remarkably good because these settings are in places that are, you drive up to the psychologist's office in a small town and people know that you're going there. These are places that would take that stigma away a little bit, and they've been very, very successful. I'm not that familiar with it, but I've just heard about it.
Yeah, so Liz, I think the other group that we didn't talk about in terms of the community providers to pull into this net is the mental health providers. You know, because some of these, I mean, and the other issue is that people with mental health disorders, I have the privilege of working with some folks who do this kind of work, and so what they remind me repeatedly is people with a diagnosed mental health disorder, their average age, their lifespan is 20 years younger than the average American without a mental health disorder. 20 years. This is a lot. And so these are folks, in terms of moving back into the disease trajectory. If we can get to these folks in terms of the medical conditions earlier in life, we might actually be able to decrease that mortality gap at 20 years. But it's pretty striking.
Yeah, in my practice, this is probably the fastest growing area, telemental health, telebehavioral health. And one of the reasons is, if you really think about it, you don't have to lay hands on patients. The ability to communicate is the treatment in itself. And so we find a lot of people now seeing the advantages of telebehavioral health. Now, having said that, again, as the lawyer, I'm the wet blanket. There are a ton of regulatory issues you have to pay attention to, treatment of minors, imminent danger to self, imminent danger to others, and some of the other things too. And we've been working on a 50-state survey looking at some of those issues and looking at it by different kind of providers, psychiatrist, clinical social worker, counselor. But I think this is a very fertile growth area for telehealth. The other thing I will say is that there were two articles, one in the Wall Street Journal last fall, one in the New Yorker earlier this year about text therapy. And if you had told me that this would be a booming area, I would have laughed at you. But what essentially it is people pay a monthly subscription, $25 to $45 a month, and you text, usually a social worker, sometimes a counselor, and you engage in text communications about various mental health issues you may have. You actually never talk to that particular provider, and it's booming. It's very convenient to people. People find it's a way to communicate. Clinically, I'll leave it up to others regarding the effectiveness of this, but it's a booming area. So telemental health is a huge growth area for telehealth.
They are. They absolutely are. In terms of not just the mental health disorders, but PTSD. And so there's a lot of lessons to be learned from your local VA providers. The other thing is if you want to appeal to, talking to your hospital partners, who are some of the folks they have the hardest time with the frequent readmissions? It's the people who have the physical, medical issues and behavioral health issues, right? If you had a nurse practitioner, psychiatric nurse practitioner, you could dispatch to help with some of these things, you would more than pay the salary of that person, because this is such a huge need. And if you think about your own outcomes in terms of some of these patients that are so complex, a lot of them have mental health issues. And I don't mean, I don't mean schizophrenia, I mean anxiety, depression, things that are treatable and addressable, so.
And probably the largest video-based remote patient monitoring that's growing right now. Just because one of the scarce resources with mental health patients, it's one of the most scarce resources. So to be able to increase efficiencies using a video-based remote patient monitor system and having the mental health resource on one side, being able to do it more rapidly, is one of the areas that we see growing at a faster pace than others.
Liz, I don't mean to put you, I guess I do mean to put you on the spot with this. But I think behavioral health providers were also not included in the high-tech meaningful use incentives. So behavioral health and post-acute care providers are often lumped together in terms of their solutions. Is there anything that the ONC is doing that sits at the nexus between long-term care and behavioral health, or ways that the agency is addressing both of these populations that are useful in bringing them together?
Well, I mean, I think what we're trying to tease apart, I mean, one of the barriers, as I think most people are well aware of in this room, are the challenges around how to address 42 CFR, so which is it's a federal regulation related to sharing information related to substance abuse and other types of protected information. And so what has happened, I think, in a lot of areas is that there's just a fear and lack of knowledge around what to do with that information, so nothing moves. And so I think what ONC is looking at is trying to tease apart and provide clarity, and in partnership with SAMHSA, around the kinds of information that is covered under HIPAA and that could move under those protections, and the things that are that's clearly covered under this 42 CFR regulation. So it's an area that we see as a key area of opportunity. Again, provide clarity, so maybe I don't know if the attorney wants to say anything. Do you have anything to say about that?
The only thing I'll say is that remember, HIPAA is a floor. So if you've got state laws that are stricter than HIPAA, then they apply. So it's not just federal HIPAA you have to worry about. And particularly with regard to mental health, a lot of states have very onerous requirements and restrictions as to how you handle mental health information.
Any questions? Either on this or in general? Any experiences you'd like to share? Yeah.
Not so much an experience, but it's a question for all of you up here.
2 seconds. Wait. Coming.
It's a question for all of you up there, and I'm Penn Hoyt, and I work for Vendor Access, and we're a software provider. But this is from my perspective with the telehealth that's coming on through and the amount of information that is available putting through a device or an implant or seeing it on computer, and then with CMS and with governmental agencies and what happens to that information, who has access to the information. How do you guys work together to make sure those roadblocks aren't in place, so when you have a family member who is trying to get that information and is told, no, you can't get that information, how does that happen, or is concerned about where's that information being transferred to? Do you guys work together, or does the technology get done in first and then suddenly someone goes, whoops, we didn't think about that, and suddenly you have to go back and forth on that? That's kind of how are you working together to branch that so it's not so tight that no one can get anything unless they've got, level 5 government security clearance, but not so loose that I can go on randomly on Google and say, so what did this person go to the hospital for, type of thing.
You want to?
Chris. I think most manufacturers and vendors are trying to take look in their own house first, and trying to put stopgaps and safeties inside of their information, whether it's making sure that any messages going from a home back to the server is encrypted, not marrying information, and then letting the other pieces kind of fall into place. I think the first thing that most are doing right now is just looking at what they control, and if they can make the information that they control safe, then it trickles down and it should continue to stay safe. But there's not, especially when you look at between the government and manufacturers, mainly any discussions that are going on there is lobbying for things like reimbursement and lobbying for those type of things versus really having in-depth conversations on how to make something probably better.
Yeah, likewise, I would agree. Most are operating a business, so looking within their own systems, obviously for operability first is kind of key. So, but if you're doing it right, you also want to keep a mind of the future, and where data will need and systems need to cross-correlate amongst each other. So I think the key thing here is operability first within your own systems for your own customers, your own groups, and then start looking at designs for external sharing, interworking, and interoperability. So I think that's generally, as Chris mentioned, what companies will do first is to get their systems operational first.
And there is a lot. I shouldn't make it sound like there's not a lot of the discussion being done, like between remote patient monitoring and EMR companies. There is a lot of that going on. And again, if you're looking at a new EMR company, ask them who they interface to, because again, at the end of the day, to get the right information, the right people, at the right time, if you go with an EMR that's not talking to anybody, you're going to end up doing a lot of cutting and pasting and a lot of extra time and those type of things. But there are several of the best EMR companies that have interfaces to remote patient monitoring companies. The top remote patient monitoring companies have interfaces. I mean, even to people like Epic. I mean, Epic has interfaces to, I think there's 4 now remote patient monitoring companies. And I would say that both of us sitting on the panel have interfaces to Epic. So they're out there. So it is being done.
Until you get to the Internet of Things or the apps, in which case it's, like I said, the apps in particular, because that is an unregulated market. And the FDA, to be clear, has identified that they're not the people. They don't have the standards and mechanisms in place to regulate these apps. You know, the only way they get involved is if it's an app that actually uses something that's FDA approved. So if you're relying on the FDA to sort of say which apps are good, I don't think that's going to happen anytime soon. They just don't have it's not within their purview to really do that. The Internet of Things is the other piece. There's a lot of discussion in the security, in the electronic security discussion, actually, about, you know, the Internet of Things and security and how good does it have to be. You know, it doesn't. You know, you don't have to have a firewall on your thermostat necessarily, right? Like you have on your bank account, but you need something so that, you know, the guy driving down the street who wants to do something nefarious can remotely change your thermostat. And that is, I'm not making that up. Those of you who don't know Nest thermostat, you actually can do that. Like my iPad, I could be messing with my daughter and setting the thermostat differently at home. I could just mess with her. I might actually have to do that.
Any comments?
The only thing I would say, I think, to a broader point, I don't think there is effective enough communication among industry, the federal government, particularly the federal agencies, and state. We haven't talked a lot about it, but the states do play a huge role in a lot of this too. Well, we've just ignored that in the discussion today, but they play a huge role. I don't think there's enough communication. I don't think regulators understand where the industry is going. They don't understand the technology. They don't understand how quickly it's advancing. They have no clue. Clinicians sometimes are behind too. I've talked to a lot of doctors. All this wonderful information, this technology is getting us. Doctors are afraid because they say, now we have all this information. Now we have a duty to act when we get it. We're not prepared for that. And so there are a lot of things that we need to think about that are sort of in between the lines. The technology is leading the race, but I think clinicians, the law and regulations are far behind, and we got to somehow find a way to bridge that gap.
Well, I'll say in response to that, I think one of the, at least on the ONC front, and I think also at CMS, as we think about some of the models that are emerging, and particularly I'll call it the state innovation model. ONC is supporting these 34 states through a Health IT Resource Center. So we have regular conversations actually with the states around various interoperability topics. And so there is opportunity, I think, over the next many years to kind of refine and address some of these challenges and barriers. The other thing to note is that ONC also has 2 federal advisory committees to address policy issues and standards issues. And so we do hear regularly from, I think, the states and other public sector stakeholders around a whole host of issues. One of the agencies I think that really encourage that dialogue, and so just wanted to share that.
So being mindful of the time, I'm going to ask our panelists one last question. I know. And begin to think through how to make this actionable and what to do. So my question for the panelists, which I will begin to answer from where I sit, is, what is our takeaway here? What, as home health agencies, as the VNAs, can and should we be doing to really bring to bear telehealth and health IT in our agencies, and how can we impact what's happening at the federal policy level? So my quick answer, other than getting on board the broadband for everyone movement, which is clearly all of our first steps, is to tell your story and to share it. I said this earlier, I'm speaking both, as a DC-based advocate, but also as somebody who works with the NAA to really share your stories. Some of the innovations we have heard today are amazing, and some of the challenges you are raising and the barriers that you're articulating are extremely important to articulate. So to the extent possible, at the state level, at the federal level, and within the VNAA, please be sure to share these stories and find ways to articulate both the barriers and the enablers so that we can all help together, to the point of the last question, to work together to share this across the systems. So we'll start, Chris, down with you. What is your takeaway for people? What should they be doing, and what do they need to focus on?
I think, as I talked about earlier, look at opportunities inside your organization to expand the patients that you might not currently be using technology for. So if you're just using it on home health, look at some of those other areas, especially AMI, pneumonia, COPD, post-hip, post-knee. I would also say the other big thing is look at your organization and the especially acute providers around, and look at being able to put services and offering together to help those organizations manage their non-homebound patient population post-discharge, because those are the big rocks in their shoes that they're needing help for, that you could actually help them with. So those would be two of the things, if and you could start today and move forward with them.
Yeah, I would say use cases, feasibility studies, any opportunity again to show where telehealth is working, from a customer perspective, where it's saving money and time, driving efficiencies, where you're able to get data that is actionable and useful, that's essentially driving healthy outcomes and preventing interventions. So again, the more we can share, the more likelihood you're going to be able to drive something like the need for broadband, because a lot of telehealth requires good communication infrastructure, and that's changing also, by the way. I know that the the internet service providers, the telephone companies, the broadband service providers, they are changing as well. They're going through an evolution where there's an elimination of the copper that we have in the ground, and more of that is moving to a wireless connectivity capability. So until that evolution happens, then we're going to see more ubiquitous broadband, where you're going to get premium services for high definition video, or you're going to get lower cost services that will help drive and improve telehealth, utilizing lower cost broadband capabilities.
Home care agencies have great stories, and I think we don't tell our stories enough. And I say that coming as a provider. Remember, I was a provider and I ran an agency, and I was busy with day to day. I mean, making sure we could take care of our patients. I think the other group, in addition to talking to your legislatures, both state and federal, is to make sure your newspapers and your local media outlets know what you do, because there's nothing like that story with a picture of somebody who can stay at home because of you that makes a difference in the community. The other piece I'll sort of add on to is don't forget the behavioral health, mental health patients, because I think this is an untapped opportunity where there's real need and things that you can actually do. And I know it makes staff nervous sometimes because they say, whoa, 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 I was never trained. You can actually provide that kind of, they can get what they need through continuing education to be able to effectively care for these patients. The reality is they're already caring for them, right? I mean, they really are. So, and then my final piece is let's try to move back in that disease trajectory because, this is going to affect all of us. So not just as providers, it's going to affect us personally unless we get better at getting action earlier in the disease trajectory to keep people as healthy as possible. We're all aiming for that mortality cliff. Remember, we've all seen this kind, right? The downhill. We want to be on the cliff. Live to 85 years old, one day you wake up, boom, you're gone, done. Right? That's the way we want to go, right? So we don't want this long downhill decline and all these kinds of pieces. So,
just to echo what everybody said, to the extent that agencies have telehealth programs in place to track data on patient outcomes and other things as well. And then the other piece is educate, educate, educate. I think a lot of your state legislators, regulators, media need education on what exactly you guys are doing, how you're doing it. And also how it impacts the populations you're serving. I know that I heard, I forget the lady's name, but she runs the University of Mississippi Health Center telemedicine program, and I saw her go on Hill visits, and she had a bunch of data, great stories to tell. It made a tremendous impact on the people who were listening.
Thank you. And I would just encourage a couple of things just to think about, we talked a lot about EHR today, but thinking about other health IT technologies that really can help you out. I think things like, ADT alerts, different kind of alerting technologies will let you know sort of when your patients are moving across care settings, so you have an idea when are they going to the ER, when are they being discharged, and you can able to better have some insight in coordinating that care. One of the recent statements that was made to me was that how many times agencies go out to the home and they're not there, and so having better insight into where are your patients, and then again managing that both the clinical and the service side and thinking about again 50% of Medicaid home community-based payment now is going on that social service aspect. So thinking about managing all those various services and your role in that, I think, would be
terrific. Well, with that, we'll wrap up. Thank you guys for sticking with us for so long, and please join me in thanking our participants.